الأمين. بسم الله الرحمن الرحيم والصلاة والسلام على رسول الله الأمين سيدنا محمد وعلى آله وصحبه وسلم. I am Professor Ahmed Mitwalli, the founder of the society. I've been honored and happy to introduce this webinar, which is one of the activity that your society is doing every month almost. And we're happy to today invite Professor Jorgen and Dr. Agada to be the moderator. And I'm very thankful to the Bayer company for supporting this activity. If it wasn't because their support, we wouldn't be able to be online on this webinar. Please, I will leave the floor now to Dr. Agada Ngawi to introduce Professor Jorgen. Thank you very much.
Thank you, Prof. Assalamu alaikum wa rahmatullahi wa barakatuh. Hello, everyone. It is my absolute pleasure and honor to be moderating this session on a very exciting topic and with a world expert who really doesn't need any introduction because he's very well known to the nephrology community. Professor Jürgen Flug trained at the Hanover Medical School, Germany, the Albert Einstein College of Medicine, New York, and the University of Washington, Seattle, USA. He was the head of division of nephrology and immunology at the University of Aachen, Germany, from 1999 to 2023 July. Thereafter, he was awarded the position of a senior professor at RWTH Aachen University Medical School. Professor Flugi is a former executive council member of the International Society of Nephrology, the European Renal Association, ADTA, and KDIGO. He's a distinguished fellow of the ERA, DTA, and recipient of the award in 2019 for his outstanding clinical contribution to nephrology. He is also a past president of the German Society of Nephrology and the recipient of the 2020 Wohlard Medal of the Society in honor of all his achievements. Together with Professor Richard Johnson and Marcello Tonelli, he edits the best-selling textbook of comprehensive clinical nephrology, which I'm sure every nephrologist listening to this talk has on their shelves. In fact, I have it next to me right here as I'm reading this. Finally, Professor Flugi is Associate Editor of Kidney International since 2018 and an Editor-in-Chief of the Clinical Kidney Journal since September 2023. Until 2017, he served as an Associate Editor of Nephrology, Dialysis, and Transplantation. His research interests encompass both basic research, specifically studies looking at progression of kidney disease and kidney fibrosis, as well as clinical research, specifically in immune-mediated renal disease, such as IgA nephropathy, as well as bone and mineral disorders and cardiovascular disease in uremic patients. He coordinates the KDIGO worldwide guidelines on the management of glomerular diseases. His scientific work encompasses more than 750 original papers, reviews, and editorials. Without further ado, Professor Fugan, the floor is yours.
Excuse me, just give me 1 second. I made a mistake. The one who sponsored this webinar is GSK, and it's not Bayers. I'm really sorry, and I apologize to our friend GSK for this simple mistake. And GSK are always behind us. They always support us. And this is not the first time they are behind us, and they're giving us a lot of support. Thank you, GSK, for your support. Please go ahead, Professor.
So thank you so much for the kind invitation and the very kind introduction. It's always nice to hear what you've done. And it makes you humble. So today I want to talk about lupus nephritis, but before I do so, this is my funny university. It looks a little like the Centre Pompidou in Paris, if you are ever there. And the funny thing about this university is that the trees you see in the back here, that's a different country, that's Netherlands. And if you were to look over here, you would see Belgium. So I probably have the only nephrology office in the world from where I can see 3 countries. So lupus. In 2021, we finally managed to update the glomerular disease guidelines, including lupus nephritis, and it was long overdue because the first ever guideline on this topic was published in 2012. So clearly there was a huge need to update these guidelines. And you will see that we now have a model where we continuously update guidelines so that no more than 3 to 4 years elapse maximum before we have an update. So whenever you have a patient with lupus nephritis, this recommendation is still the very basic recommendation. We recommend that patients with systemic lupus, including those with nephritis, should receive hydroxychloroquine or another antimalarial. And what we don't discuss here, but what sometimes may be very insightful, is measuring the plasma levels, of course, of hydroxychloroquine. A patient that I rarely see, because it's mostly the rheumatologists who see these very early lupus cases, is the patient who, if you were to take a biopsy, has class 1 or class 2. So mild mesangial changes or hardly any changes. And what we suggested in 2021 is if you find this kind of kidney involvement, and there's low-level proteinuria, so non-nephrotic, less than 3.5 grams per day, then the kidney should not be the driver's seat, and you should immunosuppress patients based on whatever else they have. If there is nephrotic syndrome, however, this could be a case of lupus podocytopathy, where electron microscopy will show you very widespread foot process fusion. And there are many similarities with minimal change disease. And we would suggest to treat that patient with corticosteroids and another immunosuppressive agent. There are no changes in this recommendation and this algorithm in the 2023 updates. There's also no change in the update regarding class 5 lupus nephritis, so membranous lupus nephritis, where very similar to the early classes, if there's low-level proteinuria, monitor it and immunosuppress based on extrarenal manifestations of lupus. If there is nephrotic syndrome, we suggest RAS blockade and blood pressure control. And I think at the end of 2023, I would also include an SGLT2 inhibitor now, because there's increasing evidence that SGLT2 inhibitors are working well in lupus patients. And then that patient should receive combined immunosuppressive treatment of a glucocorticoid and anything else, whatever it be, and of course, hydroxychloroquine. The literature is very thin on class 5, and mostly class 5 has been included in other studies, so that the database is not very good here. This is probably the most important table, and it's most important in particular for rheumatologists. I always, when I lecture to rheumatologists, I always find rheumatologists are fantastic in treating the immune disease. But the patient with lupus nephritis is a CKD patient with immune disease. So that patient has 2 diseases. And treating the CKD with everything that we as nephrologists are used to is at least of equal importance as treating the immune disease. And of course, this is minimizing cardiovascular risk. This is treating proteinuria. This is doing something about the infection risk. This is caring about bones, etc., etc., etc. And in fact, this is a rather incomplete list. And clearly, we have more means of treating chronic kidney disease, including normalization of weight, which I guess in most countries in the Arab world is a huge problem. And watch out for the exciting studies that come out with semaglutide. We need to talk about smoking. if you smoke and you have lupus nephritis, your prognosis goes downhill extremely rapidly. You need to talk about salt intake. And what is missing here are SGLT2 inhibitors. It's not yet in the guideline update because there is no formal lupus study, but the database is getting better. And of course, what's missing here is COVID vaccination. I think that should now be an essential part of influenza pneumococcal vaccination. Now, let's go to the most important changes. This used to be the recommendation for the patients that I see most frequently, class 3 or 5 with and without a membranous component, so with and without class 5. And the old guideline says, if you have a patient like this, treat that patient with steroids and low-dose IV cyclophosphamide, so the Euro-Lupus scheme, or mycophenolic acid. And the evidence base was quite good. It's a 1B recommendation, 1 meaning most people would do it. We recommend as opposed to a 2 recommendation. We suggest many people would do it, but many would not do it. And B implies we have a pretty high degree of certainty. This has changed quite markedly. In addition to MMF and low-dose IV cyclophosphamide, we now recommend belimumab with mycophenolate or low-dose cyclophosphamide, a 1B recommendation, so pretty strong, or mycophenolic acid and a calcineurin inhibitor when kidney function is not severely impaired, and arbitrarily the limit is set as 45 mils per minute. Another 1B recommendation. So you have much more of a choice now. And I will go into the issue, which patient may be best suited for which therapy. We also recommend that if you use corticosteroids in induction therapy in the patient with very active lupus, you try to go as low as possible and try to use the reduced dose steroid regimen during initial treatment of active lupus nephritis when there is satisfactory improvement. Of course, you may need to go up if there is no response or no improvement, but you can see here that already after 4 weeks, you're down to 15 milligram, and after half a year, you're at really tiny, tiny doses. But we have learned so much about corticosteroids and in particular infection events that I think there's wide consensus amongst rheumatologists and nephrologists to stay as low as possible. And then we have a number of practice points. Practice points are not guideline recommendations, but they are important points we want to make where there is no good evidence, but we feel it's important to make these points. And this is to help you select the right patient for the right therapy. So IV cyclophosphamide is ideal, of course, for a patient who has difficulty adhering to an oral regimen. Mycophenolate, if there's high risk of infertility following prior cyclophosphamide. Calcineurin inhibitors, if the kidney function is still quite good, and again, just to remind you, 45 is the arbitrary cutoff for the GFR. And in particular, if there's nephrotic range proteinuria, these patients seem to respond really well to calcineurin inhibitors. And if mycophenolic acid and cyclophosphamide is not tolerated. Belimumab, we recommend on top of standard care, so steroids and mycophenolic acid or cyclophosphamide, in particular in the patient with repeated renal flares or at high risk for progression to kidney failure. Azathioprine or leflunomide, only if there's intolerance, lack of ability or cost concerns, but clearly this is not the preferred therapy, and if I were a patient, I would not want to have it. And rituximab, you all know that there was a negative trial in lupus. It's now being reinvestigated, whether that was falsely negative. but clearly right now it's a rescue therapy limited to those with persistent disease activity or inadequate response. Now, what about maintenance? So you've induced your patient with induction therapy. Ideally, that patient is quiescent and in remission. And we then recommend that you continue that patient on mycophenolic acid for maintenance. This was the status in 2021. We now have a big table in there where, again, we stress that MMF is the preferred treatment based on high level of evidence. It has a lower flare rate than azathioprine. Azathioprine should really be not be used unless you have a big cost problem and unless the patient is pregnant. It's probably the only one where we have data on pregnancy except for tacrolimus and cyclosporine. Belimumab, so far the safety has been formally demonstrated in a trial which lasted 2 years and half a year of extension. So this is preferred, but any of this should be continued if there's good response initially. We cannot give you good guidance on how long to do this because we simply don't have the data so far, but very clearly I would not stop it too early. Now, as you know, there is a huge number of studies going on in lupus. And I'm very certain that in 5 years from now, we will be discussing probably 10 different drugs which are licensed for use in lupus. I want to focus on the red ones. Very short, briefly touch on telitacicept, which is one of the ACCEPts, so a combined BAFF and APRIL blocker that inhibit B-cell proliferation and maturation. I will not talk about rituximab. We will talk a lot about belimumab. Anifrolumab is a funny thing because the trial with respect to lupus nephritis was kind of inconclusive. Nevertheless, the company has now started a phase 3 trial with this interferon antagonist, and we will see. Baricitinib, a JAK inhibitor, failed in lupus nephritis. And we will talk about calcineurin inhibitors, which are really emerging. I personally have great doubts whether sirolimus should be used. It's listed here under the calcineurin inhibitors, but of course it's an mTOR inhibitor. So we will focus on these two. But this is what we're talking about today. And as you can see from all the other red boxes, we will talk about many, 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 many other things tomorrow. So let's start with voclosporin. Voclosporin is a really funny molecule. So you can see tacrolimus, and this is cyclosporin, and you see this cycle. Voclosporin has one hydroxy group added to cyclosporin. It's a minimal change of cyclosporin, and this change induces that it has stable pharmacokinetics. You need no trough levels. There's no dose adaptation, at least in moderate eGFR reduction. It has a higher potency, and there's a better lipid and glucose profile, in particular compared to tacrolimus. So it's very amazing to me, who is not a chemist, what one tiny hydroxy group in a molecule can do in terms of pharmacokinetics. Voclosporin was tested in the 2 Aurora trials. It was tested at different doses initially, and then it was added at 23.7 milligrams twice daily, and then continued over into the Aurora 2 trial, which lasted up to 2 years. So we have a total observation period of 3 years for voclosporin. Note that quite a number of the patients didn't go into this extension phase, the Aurora 2 trial. What voclosporin does, if added on top, and let me go back here, it's always added on top of MMF 2 grams and oral steroids. What it did is it increased the number of patients reaching complete renal response at both half a year and 1 year. And it increased the number of patients with a partial renal response. And renal response was mostly defined through proteinuria and a stable GFR, and no administration of rescue therapy and no increase or high-level corticosteroid therapy. So it's a complex endpoint. Let's look at the more familiar things. This is proteinuria. So the patients started in the nephrotic range around 4 grams per gram of proteinuria, and they nicely decreased. And they decreased more with voclosporin than the control group, and they consistently stayed lower over the 3-year study period, and even after the therapy was ended. This is GFR. Now, GFR is interesting. In the control group, you start immunosuppression, GFR goes up, and it stays up, and then maybe falls towards the end of the 3 years. In the voclosporin group, GFR decreases, but then stays at the same level and maybe increases here, but essentially stays at the same level. In terms of side effects, there was no real signal for infections and infestations being more common in the first year. It's 60% here, 60% there. But there may have been a small signal in the second and third year, 30% versus 39%, 24 versus 34. The same is true for hypertension. There was much more reports of hypertension and GFR decrease compared to the 6% with control. But this then got smaller and lesser as the study continued. So it does the typical things of a calcineurin inhibitor. It has an acute effect on eGFR, it does induce hypertension, and it does lead to a moderate increase in infections, in particular in the later treatment phase. In terms of renal flares, adding voclosporin did not affect the number of renal flares. The adequate response initially was better, as I showed to you, but then subsequently, the number of flares didn't differ between voclosporin and the controls. Now, this complements data from China. So this is 300 Chinese patients randomized to tacrolimus or IV cyclophosphamide for 20 weeks plus prednisone. And you can see that, if at all, the proteinuria decreased more with tacrolimus. But if you look at the serum creatinine, it increased with tacrolimus and decreased with the cyclophosphamide infusions. So once again, supporting the idea that calcineurin inhibitors are great for antiproteinuric treatment, but not so great for preserving GFR. Serious study, drug-related treatment emergent adverse events were pretty much lower in the tacrolimus compared to the IV cyclophosphamide. But if I go back as a nephrologist, I would like to see this. I would like kidney function to get better, because at the end of the day, this is what I'm interested in. What is not yet in the guidelines is telitacicept. So a BAFF and APRIL antagonist. There's a Chinese trial. So far, it's only licensed for use in China. Telitacicept subcutaneous at 160 milligrams per week. And what they saw is that the primary endpoint, the SLE responder index 4 at 52 weeks, was much better with telitacicept. And in terms of adverse events, Well, they had an infection signal, and quite an infection signal. If you look at this, there were 10% more upper respiratory tract infections, and that's logical because you do induce with all the ACE-sets, everything that inhibits APRIL and BAFF will lead to humoral immunodeficiency, and you inevitably depress IgG, IgM, and IgA. Now, let's switch over to belimumab. This is the key trial, BLISS-LN. It's a large trial, 450 patients, half of them Asian, most of them, as is typical, class 3 or 4, sometimes in combination with class 5, and only 16% had a pure class 5. They had a good kidney function when the trial started. They were moderately proteinuric, so some nephrotic, some subnephrotic. Most of them received an antimalarial, and I don't think this is ideal. Only 67% were on a RAS blocker, which to me should have been 100% if tolerated. But be it as is, these patients were given belimumab, 10 milligram per kilogram IV on day 0, 2 weeks, 4 weeks, and then every month on top of standard of care. And standard of care was steroids. Most patients were on MMF, starting at 3 grams per day and then going down. But a quarter of the patients also was on cyclophosphamide, the Eurolupus scheme, and azathioprine maintenance. Now, these are the endpoints, and they're similar to what you've already heard with voclosporin. There's a primary endpoint called primary efficacy renal response, PER. And this was a stable GFR, no more than 20% below the pre-flare value, low proteinuria, and not a treatment failure. That is patients who received any rescue therapy. The secondary endpoint was complete renal response, GFR above 90, low proteinuria, not a treatment failure, and then time to renal-related event or death. And these, of course, are the very hard endpoints of dialysis, of doubling of creatinine, worsening of proteinuria or GFR, and treatment failure. So when they added belimumab to standard of care, this is what the primary endpoint was, and it was highly significant. There was a 46% higher chance of reaching the primary renal endpoint if you added belimumab to the treatment, to standard of care, over the 2-year trial. And this was true for the overall population, and if at all, even better for the Asian population. Now, I'm sorry, but I simply don't know, where do Arab patients fit? Are they more Caucasian or more Asian? I honestly don't know. But even if you pick the middle, you would be better than the overall population. Secondary endpoint, complete renal response, similar picture. 58% more likely that you reached the complete renal response. Now, these are the interesting data. eGFR. eGFR, I said the patients had a good kidney function, but eGFR increased with both treatments, and it increased a little more with belimumab, and then it stayed. Whereas in placebo, you can very clearly see that the placebo arm is losing kidney function. Here, the regression line is almost flat. So this is a major difference to calcineurin inhibitors. And as I said, I'm a nephrologist. At the end of the day, I care about eGFR, nothing else, because this will determine your fate of the kidney. What about adverse events, belimumab? Well, there were hardly any differences. If you scroll down the line, you will hardly find anything. And if you look at all serious adverse events, nothing. There simply is no signal. Adding belimumab to standard of care does not over-immunosuppress the patients. Again, a difference to the small but real signal that has been seen with voclosporin. Here's another important thing, infectious complications. If you give an interferon antibody, it's well recognized that your chances of having influenza or a more severe cause of influenza are markedly higher. And the same is true for herpes zoster. So clearly, some virus infections become more prevalent if you inhibit interferon. If you inhibit rituximab, you have a signal here for herpes zoster infections and maybe for nasopharyngitis. But look at belimumab. Everything is at the one level. There is no benefit, but clearly you do not increase infectious complications. So in terms of immunosuppression, once again, these data suggest that belimumab is a very safe agent if you add it on top of standard of care. Lupus flares at 24 weeks, 26% with placebo, 14% with belimumab. This is why I told you earlier, when selecting the right patient for the right treatment, clearly this is something that distinguishes belimumab, that it does prevent renal flares, and that it seems to preserve GFR better, and that it doesn't add infectious complications. Belimumab is also one of the very few immunosuppressive agents where we have a repeat kidney biopsy study. And what they saw in these patients, note that this is 10 only, it's a very tiny study, but what they saw is that there was a better response and histological remission, and the relapse rate was 0. And if you looked at activity indices and you compare belimumab with standard of care, you can see that there was a trend for activity index to fall a little more than with placebo. But most importantly, the chronicity index, which I really fear, was less with belimumab, suggesting you have less kidney fibrosis after 5 years of follow-up. Now, when we look at the BLISS-LN trial, I already told you that the majority of patients received MMF, 164 here, 165 in the placebo group, and the cyclophosphamide group was pretty small. What is obvious at first glance is that the patients completing the treatment, it was always lower in those receiving cyclophosphamide. So very clearly, and we have widely adopted this, MMF is our standard of care as opposed to Eurolupus scheme. In fact, I cannot remember the last time when I've given IV cyclophosphamide to a patient. I can remember, but I tell you, it's long ago. Now, when you then look at the two immunosuppressive regimens, and you look at complete renal response, in the cyclophosphamide group, belimumab didn't seem to add anything, whereas in the MMF group, there was a clear benefit for those who received additional belimumab. Why this is so, we don't know at present. It could simply be low numbers of observation. You can see that there were only 11 events in each arm, as opposed to 33 and 56 here. Could be low numbers, but honestly, we don't know. But very clearly, when you are on MMF induction and maintenance therapy, belimumab adds significant benefit in terms of complete renal response. The other puzzling observation in the BLISS-LN trial was when the investigators assessed proteinuria. the primary efficacy renal response and the complete renal response in those with a high proteinuria were lowish. Again, it's not clear why this is, but in the patient who had a low grade of proteinuria, so below 3 grams per gram, the non-nephrotic ones, there you had a big benefit. So there was a speculation that, well, maybe if you're nephrotic, you lose belimumab into the urine, but that is not likely, and there's data to suggest the contrary. So in essence, this is an observation which I find difficult to interpret. And I find it difficult to interpret because the occurrence of end-stage kidney disease, doubling of creatinine, increased proteinuria, kidney disease, treatment failure, or death, it was all similar in the two proteinuria level groups. It was consistently lower with belimumab, even in the one with high group. And of course, once again, as a nephrologist, I care about dialysis, I care about irreversible loss of kidney function. So I don't know why there's a discrepancy between these data where the primary efficacy response and the complete renal response made it look like there's little to no signal in high proteinuria, but these really hard endpoints, they were affected in the right way. Last slide, real life experience. This is an Italian multi-center cohort, 91 patients with lupus nephritis, treated with IV belimumab, plus standard of care, and followed for a little more, close to 2 years. 38% had a complete renal response, 70% had a primary efficacy renal response. So very consistently that you can reproduce this outside of clinical trials, but note that about a third of the patients still is in need of more treatment. And it will be up to us to define that better treatment. So let's sum up. We have now very much revised this recommendation of 2021. So in 2023, we would say that yes, MMF maintenance is what you want to go for. Belimumab should be given if there was good response initially. Same for calcineurin inhibitors and mycophenolic acids and calcineurin inhibitors alone. But if you compare the two, what is my personal conclusion? And in fact, it's no longer a personal conclusion because it's in the executive summary of the KDIGO guideline. So in terms of complete renal response, both voclosporin and belimumab enhance responses. The eGFR at the end of the study is similar, but here's better. Renal flares, similar, but here it's fewer. Adverse events, there's an infection signal in year 2 and 3, GFR lower in year 1, blood pressure higher in year 1. Everything's similar here. Important restriction, don't use it in pregnancy, both of them. And don't use calcineurin inhibitors if the GFR is below 45. Of course, this is oral. Of course, this is IV and subcutaneous. But in essence, I believe we have a very promising drug here. And in a few weeks, you can read all this in the executive summary of the KDIGO lupus nephritis guideline. And just today, we finished the galleys, so it should be out soon. Thank you all for listening to me, and I very much look forward to your questions.
Thank you, Professor, for an outstanding talk and very, very comprehensive review of the updates. It looks like we do have a number of questions lined up already, so I might as well start with those ones. So the first question that we have is, what is the best treatment for persistent lupus nephritis after initial treatment? So they're talking about persistent or resistant disease.
Very hard to say. I mean, one colleague of mine put it very nicely. He says he doesn't believe that resistant lupus nephritis exists. If you talk to your patient, if you monitor their therapy, it doesn't exist. Which of course is an important discussion because you may have seen the Nature Medicine paper on CAR T cells curing resistant lupus. But of course, it's CAR T cells. You need a bone marrow transplant. You need induction therapy for that. So it's very, very costly. It's still very experimental. And I believe the key is that you have to explain to a 20-year-old why she usually needs to take all these pills, maybe for the rest of her life. And if they don't understand it, you have resistant lupus. To me, that's the most important aspect of resistant lupus. Yes, there is true resistant lupus, and we don't know very well what to do. Maybe rituximab, maybe CAR T cells in the future.
Yeah, that's great. Another question that we have on safety of voclosporin in pregnancy and beyond 3 years of therapy.
Well, voclosporin so far is not licensed for use in pregnancy. And the FDA said that because in the voclosporin preparation, there's a tiny amount of alcohol. Tiny. Whether that is really a problem in pregnancy, I think nobody knows. Cyclosporin and tacrolimus we give in pregnancy. And I've shown you the molecular formula of voclosporin. It's very, very, very similar to cyclosporin. So my gut feeling is that as time goes by, we will find that voclosporin can be given in pregnancy. But that's a gut feeling. Right now, don't do it.
And I guess the same question goes for belimumab, because I know that there are emerging data that it is probably compatible with pregnancy, but I guess still even in the updated version, it's not okay for pregnancy.
Well, it's the same with all of these drugs. I mean, this is how we found out that you can give cyclosporin in pregnancy, because some transplant patients got pregnant. And as time goes by, we will learn. And I totally agree with you. Belimumab is probably safe in pregnancy. And this is very important because we need drugs to keep the lupus quiescent after we stop the MMF.
Absolutely. The next question, it's asking about drug interactions between MMF and PPI. Is there any? And are there any interaction between PPI and cutaneous lupus? Yeah.
That's a tough question. Honestly, I don't know. I'm just giving PPI. I mean, they're way overused, but I'm not aware of major drug interactions. I honestly don't know. And lupus, cutaneous lupus and PPI, I can't imagine what that interaction should be.
So the next question comes from Abdul Hamid. Rituximab and Benlysta. Oh, sorry, I lost the question. There it is. Rituximab, Benlysta, obinutuzumab. He's listing all the options in severe lupus nephritis, but there's no question. He's just listing the medications, but to me, there's no question. I'll just move to the next.
The denosumab that shouldn't be in there.
Yeah, I don't know what's really the question, so we'll probably just keep going. The next question: why SC and low doses Benlysta can prevent de novo lupus nephritis while higher doses failed? Subcutaneous. Why subcutaneous and low doses Benlysta can prevent de novo lupus nephritis while higher doses fail? That's the question. Any link to higher doses with IL-10 inhibition and flares of lupus?
Again, a very interesting issue. I think there may be a signal in that way, and there probably is an immunology behind it, but too early to answer. We don't know for sure. Even the fact that high doses may be less effective.
And then we have a question about Benlysta and neurolupus and patients with depression. Again, no clear question, but maybe they're wondering about the use of Benlysta and neurolupus.
I'm not aware that there is. Well, first of all, there are no good trials, of course, in neurological lupus, but it certainly isn't contraindicated. I don't think it's, and this is a question to the rheumatologists more than to me, I don't think there's a good evidence base that belimumab is very effective there, nor do we have evidence that it's a problem.
And then we have a question about combination of rituximab and Benlysta. If we were to give it, which one would you consider first?
Oh, the Benlysta, very clearly, because Benlysta is what we now have safely established and firmly established to be effective in lupus, whereas rituximab is still discussed. And you will see that in the guidelines, rituximab, yes, it's mentioned, but it's mentioned as something to be explored.
Correct. We have a question again about pregnancy. If B-cell depletion therapy is mandatory in pregnancy, which agent is more safe and when to give it?
Well, I don't know how you can conclude that B-cell depletion therapy is mandatory. In pregnancy, probably you have to find out whether calcineurin inhibitors can do the job. And with calcineurin inhibitors, I mean the classical ones. And of course, azathioprine in a way is a B-cell inhibitor therapy, not depletion therapy. But that's all you can say about pregnancy. I think the experiences with rituximab, yes, they are there, but it's not solid enough to make a statement that rituximab is absolutely safe.
And it's largely reserved for life-threatening or organ-threatening instance. Agreed. Then we have a question about, is the combination of mycophenolate and belimumab more effective than single therapy?
Yes, absolutely. This is, I mean, it hasn't been tested as single therapy. All the trials are MMF and steroids plus belimumab or no belimumab. What we don't have is steroids and belimumab versus MMF.
Correct.
Unknown.
And I guess we kind of sort of all agree that patients who are resistant or who are to therapy, there's no question that we would want to think about those alternative regimens. But the question that I do have in mind, when would you consider to start belimumab or voclosporin upfront in someone who's just presenting, who are treatment naive, they've never been treated before? Would you consider that option before trying the usual traditional cyclophosphamide and mycophenolate mofetil?
Well, in the ideal world, yes, but we don't live in an ideal world. Very clearly, both voclosporin and belimumab add significant cost to the treatment. So for me, the patient who presents with, let's say, class 4 lupus nephritis and still has good kidney function and responds very well to early steroids and MMF, I would probably be reluctant to add voclosporin or belimumab. Whereas the patient who has more severe disease, I would probably give belimumab to that patient in addition to MMF and steroids. So it depends a little bit on your patient. And then the characteristics of how these patients evolve in the future. In the ideal world, if I had all the money of this world, I would probably give belimumab to most of my lupus patients. But
upfront, I see. Yeah, and we also have a question about pediatrics population. What was is there any therapy updates for lupus nephritis in peds, and is adding belimumab part of the therapy?
No update there. I'm sorry to say, as usual, you poor pediatricians, you suffer that nobody is doing trials.
Another question that I had in mind, it's not really related to the alternative regimens or belimumab per se or voclosporin. It's about lupus podocytopathy. This entity, whenever we face in clinical practice, and sort of the recommendation is to treat them as minimal change disease, but reality is minimal change are typically treated without maintenance therapy necessarily. We would treat, and then if they go into remission, we just observe. So what's the case with lupus podocytopathy maintenance therapy wise? Would we continue after they respond, or would we give them a trial of no immunosuppression and observe? What's your recommendation or advice?
Well, lupus podocytopathy, we're only just starting to learn about this. You know, this super interesting story that is coming for minimal change disease with nephrin and maybe even other antipodocyte antibodies. If that is the origin of lupus podocytopathy, then you would have a good rationale to give them immunosuppression. Maybe in the future we have a biomarker. But that's pretty speculative right now, but it's very compelling. And interestingly, there's an old study which has largely been ignored. It's some 15 years ago. Dr. Holthöver's group published anti-nephrin antibodies in type 1 diabetes and lupus. So if that is the case, and you have a persistent production of anti-nephrin antibodies, you can use these to guide your immunosuppressive treatment. But this is really talking into the future. Right now, it's try and error. Treat them with a calcineurin inhibitor. That would be my preference in the nephrotic lupus podocytopathy. And then at one point, taper down. But the likelihood is you will see a relapse.
It is very interesting because the response is dramatic. They respond like typical minimal, like within no time, but then the relapse is also dramatic when it happens. So
within 1 year after stopping tacrolimus, you have 80% relapse. 20% don't. So it's worthwhile. The point I'm making is it's worthwhile to attempt to stop. But usually my patients would ask me, can I please stop?
Yeah, it's always driven by the patient. That's true. We have another question from the audience. Will you consider shifting between cyclophosphamide and MMF for non-responders or adding Benlysta?
Well, for a non-responder, as I said, if there is a question of non-adherence, very clearly IV cyclophosphamide is a good treatment for them. And Benlysta also, once you have it in, it's in. And you have no problem with non-adherence. So both of these would be great in the patient who fails to respond to MMF plus steroids. Switch them to IV cyclophosphamide plus, if the disease is more severe and not mildish, plus belimumab.
And another question, if I may, about hydroxychloroquine, because I found it interesting. You mentioned something about measuring the levels or following the levels. Has that been used in clinical practice? And if yes, how is it usually? No, so okay.
No, it hasn't, but it's an emerging story. First of all, you can nicely measure adherence of the patients. And what you not infrequently find is, I mean, most of us are giving one dose of hydroxychloroquine. What we often find is you underdose. And dosing according to plasma level is something that is only just emerging, I think.
Yeah, I think it would be very, very interesting because a lot of patients, the adherence issue is, I guess, across all the medications. I really thank you for this excellent talk and all these questions and discussions. I have to salute the glomerular disease working group for the guidelines. They've been very informative. We absolutely, I'm sure not just myself, we love the schemes, the figures, touching on things that are not necessarily just immunosuppression, but the stuff that we have to do prophylactically to protect the patient. One of the points that I found very, very helpful is the practice points, where there is no really there isn't an evidence. And it got me thinking about practice points, how much of this we can apply or generalize, since they're really practice points, and whether or not we as communities, we should develop our own population-based practice points. And I'm just interested to hear your thoughts about that.
Well, help us to make them even better. You know that every update, every guideline goes through a public review. So if you point out that you want or need a particular practice point, help us make the guidelines more useful for you. And I'm very, very certain, after showing this slide to you with the many new emerging therapies, in 2 to 3 years, we will have to update the update. So if there's any practice point that is missing from your point of view, let us know, and I'd be happy to bring it up to the group.
Well, thank you very much. This is really great.
Pleasure.
I don't see further questions from the audience, and I guess we're coming closer to the end of the session. So perhaps I'll take the opportunity again to thank you for this great session, and if there isn't any further comments from Prof. Mutwalli or Prof. Al-Hassan, we can probably conclude.
Thank you very much, Dr. Ghada, for great moderation. Really appreciate. Dr. Ghada, as you know, she's an assistant professor of internal medicine and nephrology at King Abdulaziz University. She has many activities. I cannot number them all. And I thank Professor Jorgen, for really an excellent presentation. I really enjoyed it, and I learned a lot from you. And I have few questions, but I thought it's a good idea to give the chance to the participant. And I thank the GSK company for the support, and I thank Mr. Adham Ghanam for his presence and his continuous support to the society. And I thank everybody, and everybody attended this. And I thank again Professor Jorgen for allowing us to put this or place this, post this presentation on our site for those who could not attend to benefit from your, from what you told us. I think maybe I will leave the floor to, after this, as you said, this is your society, your support, your presence, your sharing is really well appreciated. I will leave the floor to Professor Abdulaziz Hassan if he has further questions, and thank everybody. Khalid?
At all, nothing actually, nothing to be added after both of you what you said. So thanks, Professor Jorgen, and also excellent moderation by Dr. Ghada. And hopefully we'll see you again. So just maybe announcing for another webinar which will happen on 20th of December. So see you at that time. Thank you very much. Have a good night.
Thank you.
Thank you very much. Thank you, event group. Thank you very much indeed. See you later again. Bye-bye.
في أمان الله.
مع السلامة. شكرا يا أفراح.